Hello, my name is Jeremy Larsen. I'm a hematology-oncology fellow at Mayo Clinic in Rochester, Minnesota. I'm here at the ASCO annual 2014 meeting presenting our study looking at the use of serum-free light chain assay in combination with cytogenetic abnormalities for identification of high-risk smoldering multiple myeloma. Smoldering multiple myeloma patients have a widely variable risk of progression to symptomatic disease, as this constitutes a very heterogeneous group of patients. More recently, cytogenetic abnormalities, specifically deletion 17p and translocation 414, have been associated with shorter time to progression. The aim of this study was to determine if the serum-free light chain assay used in combination with cytogenetic abnormalities could further identify a very high-risk group of patients who may have a shorter pre-malignant phase. This was a retrospective analysis of newly diagnosed untreated smoldering multiple myeloma patients seen at Mayo Clinic from the years of 1990 to 2011. Inclusion criteria were the availability of serum-free light chain assay and cytogenetic information by FISH from bone marrow biopsy samples performed at diagnosis. We screened a group of nearly 1,300 patients and ultimately identified 251 patients who met eligibility criteria. Smoldering multiple myeloma was defined by standard IMWG criteria. Free light chain assay was performed by the free light assay from the binding site. A receiver operating curves analysis was performed to determine the optimal cut point to predict progression to symptomatic disease within 24 months. A Kaplan-Meier analysis was then also utilized to calculate time to progression. And finally, multivariate analysis was also utilized to look at other known prognostic factors in symptomatic multiple myeloma. The median age of the smoldering multiple myeloma patients in this study was determined to be 62 years. The involved free light chain ratio that was determined to be the optimal cut point was greater than 40. This identified a total of 21% of patients in the overall population. High-risk cytogenetic abnormalities were defined as deletion 17p and translocation 414, and these were found in 16% of the total population. Of this high-risk cytogenetic abnormality population, the involved free light chain was greater than 40 in a total of 23% of these patients. On Kaplan-Meier analysis, median time to progression if the patient was found to have low or non-high-risk cytogenetic abnormalities in combination with an involved free light chain ratio, an involved free light chain of less than 40, median time to progression was 62 months. If the patient had non-high-risk cytogenetic abnormalities and an involved free light chain ratio of greater than 40 months, median time to progression decreased to 34 months. In the high-risk cytogenetic abnormalities group, if the involved free light chain was less than 40, median time to progression was 30 months. And finally, in the high-risk cytogenetic abnormalities, in combination with an involved free light chain of greater than 40, median time to progression dropped to 20 months. Overall, this identified three discrete groups of smoldering myeloma with varying behavior. Multivariate analysis was then performed and confirmed that involved free light chain greater than 40 maintained prognostic significance, and in addition, bone marrow plasma cells of greater than 20% and an age of greater than 65 all were adverse prognostic independent factors. When looking specifically at the 2-year progression rate in that high-risk group with deletion 17p or translocation 414 and an involved free light chain of greater than 40, 90% of these patients had progressed to symptomatic myeloma requiring treatment within 24 months. This is in comparison to the low-risk group with neither of these risk factors, so non-high-risk cytogenetics and a low involved free light chain ratio. Their 2-year progression rate was on the average of about 14 to 15%, so clearly these are two very different groups of patients. The conclusion of our study was that the involved free light chain of greater than 40, when used in combination with high-risk cytogenetic abnormalities, specifically deletion 17p and translocation 414, may identify a very select high-risk group of patients who may be excellent candidates for early intervention. We know that their pre-malignant phase is very short in comparison to the historical 10% risk of progression per year. And in the era of multiple evolving novel agents, we may need to readdress the standard of care, which is observation of these patients until symptomatic progression.